Hello everyone. Today we are going to present a case. The idea is to discuss about hypotension and its management in extreme premature infants because there are a lot of questions about the medication used in the hypotension in premature babies. So let's start the case. So we have a baby here who is 23 weeks by gestational age. The birth weight is 460 grams. The prenatal ultrasound showed an estimated fetal weight of 2.3%. The umbilical arterial Doppler showed absent end-diastolic flow, but there is no reversal of the end-diastolic flow. So still it's compatible with placental resistance, which is in itself a significant finding. The presentation is breech, and that means that baby has to be delivered by C-section. And that's what happened. The baby was delivered by C-section because baby started to develop deceleration. So at delivery, the membranes were ruptured it was clear fluid. So there was no prolonged rupture of membrane and there was no maternal fever. The Apgar was 4, 6, and 8. So infant was intubated in the delivery room and was transferred to NICU. So in this page, what we know that baby is very small. The risk factor for this baby is that baby has been not growing well. Also, because of the Doppler study of the umbilical artery, we expect this baby to have some vascular issues, which means especially, the other problems like, premature onset of pulmonary hypertension or persistent fetal circulation, which we'll talk about later. So anyway, so something to take away from this history. Now in NICU, as you see the X-ray is taken, the baby has a tube in, both lines are in place, and surfactant is given. So the main problem now is hypotension. So patient is now having a blood pressure, as you guys can see here. Let me highlight it. As you see here, 3 consecutive values are really low, and this is less than the 3rd percentile for the gestational age. Infant is already 12 hours of age. So some investigation, the CBC showed a WBC count of 1.2. That could reflect infection, or this could be because there is some history of IUGR, and mother has mild preeclampsia, which we didn't mention in the previous slide. So it could be a possibility, but ANC is very low. So that's another worrisome sign. The platelet is low and the HNH is acceptable on a baby which is 12 hours old. So we don't have to worry about that. And no urine output. So that is concerning also. So whenever you have a hypotension and you have low urine output, that is concerning, and that requires attention. The point which I want to make, that having hypotension in initial stages of life in premature baby is very common. We don't have to treat every hypertension. If there is hypotension is there and baby has a good urine output, then we should be okay in observing, because we know that kidneys are perfusing. But with the onset of PDA or cardiogenic failure, if the supply or the perfusion to the kidneys compromised, then you will not have urine output. So it's already 12 hours, and that's unfortunately not the best of the things here. So another definition which we want to do here is, people are not talking about systolic and diastolic pressure, because systolic pressures are low because of different causes, and diastolic pressure are due to different causes. And as you very well understand, that systole basically is the measure of cardiac output and stroke volume, while diastolic filling or hypertension is really reflective of SVR, systemic vascularization, and preload. So just remember that in this case, as you see, both are low. So in this case, it's both the cardiac output, the stroke volume side is also not great, and the systemic vascular resistance and the preload are also not great, because you can see that both the components of the blood pressure are low. So the certain finding on examination, the heart rate is 142. So patient is not tachycardiac yet, but capillary refill is concerning. Capillary refill is greater than 3. The saturation are like low 90s, and this patient by this point is on 40% oxygen. The blood gas showed, as you guys can see, metabolic acidosis with -12 of bicarb and lactate of 8. So definitely something is going on, that baby's perfusion is not great, and baby is going through the anaerobic metabolism, And as you guessed, now if you combine that with no urine output and now you combine with the low blood pressure, definitely something is going on and the baby is not well perfused. So this is almost reaching like the definition of shock. So anyway, repeat again. So what type of shock? Signs of shock. So signs of shock. So here in this patient, the first is met. The patient has a capillary fill time of greater than 3. Pulse is not documented here, so we can leave it there. Patient has significant metabolic acidosis and oliguria. So out of five signs are there. So this is shock. Now, what type of shock is this? Is this a warm shock or this is a cold shock? It's difficult to really decide, but as you know that initially the shock when it's compensatory is in compensation phase is warm because there is vascular dilatation, but this looks like a in the stage of cold shock with the metabolic acidosis already all setting in, and patient has low current output because you have a systolic blood pressure which is low, and now you are compensating, so vascular resistance is high. So this patient is beyond the compensatory part, but we have to do now. We take some actions here. So let's see what are the stages this patient has gone through. So the first, of course, you want to fill the tank. That's what we use the word preload. Remember, when diastolic pressure is low, it could be a volume issue, so you want to increase the preload. So that's why NS bolus was given. Total fluid remains 130 ml per kg per day. For a 12-hour-old, 23-weeker is not bad. We don't have the electrolytes in hand, but that's what probably okay. Then dopamine was started as the first line for blood pressure. It started with 5, then the drip was increased to 10. Then the echo was done at the bedside that showed a large PDA, but if you note here, the significant part was that the shunt was right to left. So this patient is showing signs of persistent pulmonary hypertension, and like we said, it could be the part of the growth restriction or vascular maladaptation in utero. So that could be a possibility. So inhaled nitric oxide was started at 20 parts per million, and then the decision was made to stop the dopamine, and because it's once you have pulmonary hypertension, if you guys remember, the dopamine causes vasoconstriction at both systemic level and pulmonary vasculature as well. So dopamine is not the good choice when you have pulmonary hypertension there in the baby. So just remember that the dopamine is not going to work, is going to be counterproductive by causing more pulmonary hypertension. So hydrocortisone was started at the test dose of 0.5 because this baby is less than 34 weeks. So it started at Q12 hour. Ultimately, it was changed to 0.5 more frequent, Q6, and then finally 1 milligram every 6 hours. So after that, the epinephrine, of course, because dopamine was epi was started on the low dose, thinking of again pulmonary hypertension, but blood pressures were not going up, and gradually it was increased. So again, the problem with this high dose epinephrine is the same which we talked about with dopamine, that it causes pulmonary vascular constriction. So at this point, the contemplation was going on what to do with the vasopressor choice. So dobutamine was added, thinking that will help with the contraction of the heart, and gradually it was increased, and epidose remained at the same. At this point, the urine output picked up. The urine output which was slight reassurance there, but capillary refill is still high, and heart rate, there's no tachycardia despite of starting dobutamine. So whenever you are choosing vasopressors, a very important thing is look at the heart rate. So here we know that dobutamine has a good beta-1 effect, which is it is chronotropic, and so you don't want any inotropic and chronotropic drug to be on board with tachycardia because that can worsen the tachycardia. So here dobutamine hasn't caused any side effects, so we should be good in using dobutamine. The repeat echo was done, and basically no change. The whole idea about repeating now, because we just want to know if the LV dysfunction is there or not, because at this point the team was making a decision to discontinue epinephrine because it's really it's a very high dose, and with pulmonary hypertension you don't want to use it because high dose of epi acts like dopamine, which causes pulmonary vascular resistance. So anyway, so this was the thing. So now at this point vasopressin was started. So and the blood pressure still remain the same, so it hasn't really changed anything. So now let's talk about three things could happen in this baby. One could be sepsis, as we saw the baby has low WBCs with low ANC. Premature birth itself is a risk, but there was no prolonged rupture membrane, and there was no maternal fever. So that's why sepsis, again, like I said, plus minus, but in premature babies, it's always on the list. We have a diagnosis established, PPHN here by echo, and we have an established diagnosis of PDA. The point we have to remember in this case that this PDA is not the usual PDA with left to right shunt. So this was a right to left shunt. So that's why the diastolic steal and all that is not classically present in this baby. This diastolic has to be due to either PPHN or sepsis. So now let's see, there are four major category, although in medicine they define in a different way. They define distributive, cardiogenic, and hemorrhagic and septic, or septic actually basically in the distributive shock. But here in premature babies, of course, first we have to look, this is cardiogenic or not. Most likely we can say it's a possibility because there's a PDA, and of course there's PPHN. So it could be cardiogenic, because you see the PFO is showing bidirectional shunt, so that is suggestive of higher pressure on the right side of the heart. What about sepsis? We talked about it, and hemorrhage could be a possibility because premature babies, breech presentation, could have IVH. There was no time to do the head ultrasound, so we don't know. But hemoglobin and hematocrit were acceptable. What about hypovolemia? It's a possibility, but the only reassuring part was that we saw some urine output, and like I said, in first 12 hour, the total fluid was acceptable. And this is the trend of the systolic. As you guys can see, we slightly saw something like around 40 something, and then it again dips down, and then up to here at this point, the systolic is running 28, and diastolic is running, if you take the mean here, is around 14. So that is definitely third percentile for blood pressure. So again, this is becoming, like we said, intractable hypotension and a challenging case. So then this table is very important at this point, that these are the list of vasopressors used in preterm babies. So like we talked about, dopamine is good. It has inotropic effects. So systolic volume, it increases. So if you are dealing with systolic hypotension, dopamine would be okay. It increases the SVR, so that's good. But see, the problem here is that it increases the PVR, same like epinephrine. But only thing is that epinephrine, remember, low dose, it's okay. But high dose epinephrine almost act like dopamine, but it has more inotropic and chronotropic effect on the heart. So dopamine and epinephrine are almost the same, and you can use it. There are literature coming that people were shying away from dopamine, but some recent studies are suggesting that dopamine is okay to use. So again, it's your unit choice, but just remember that both are not good for pulmonary hypertension. Now we are left with the other 5 drugs. So let's do norepinephrine. So norepinephrine, as you see, that is nice. Actually, it decreases the PVR. So in this case, probably norepinephrine could be a good option. So because as compared to epinephrine. Second thing also, you see that it's nice on the heart as well. So if you are dealing with a case where the patient is tachycardic and patient has pulmonary hypertension and patient has hypotension, then norepinephrine would be the drug of choice. So just remember that norepinephrine is the drug of choice if you want to use it for hypotension, especially when there is PPHN on board and there is tachycardia. So what about vasopressin? Vasopressin, again, let me rub it off so that we can focus on vasopressin. So vasopressin, the only side effect you see is it decreases the stroke volume. That's why you saw in the case that echo was done before starting vasopressin, just to make sure that there's no dysfunction. When dysfunction is there, vasopressin will further depress it, and it's like it will be counterproductive. But again, the advantage is you can use it in the pulmonary hypertension. So that's why they opted vasopressin in the case. Dobutamine is, again, like we talk about, it has a lot of beta effect, and it has no effect on SVR. Actually, some studies shows that it causes dilatation the beta 2 effect. And PVR, so again, dobutamine is good in PPHN. You can use it if you want. If there is some decreased contractility of the heart, dobutamine in the face of PPHN is okay. Now, what about milrinone? Milrinone, it is good for PPHN because it causes decrease in the pulmonary vasculature, but the disadvantage is, as you guys can see, that it causes SVR decrease, so it can lead to further hypotension. So that's why in this scenario, milrinone was not tried, because although there was pulmonary hypertension, but significant hypertension was the problem here. And epinephrine we talked about. So again, this table is very important, and this is the reference. I think we all should have this at the bedside available, because that can guide us in guiding the management of significant hypotension in preterm infants. So again, the same explanation in a graphic way, or we added. So basic difference between norepinephrine and epinephrine, as you noticed, is that first epi is dose dependent, and this PPHN is the problem. While with norepinephrine, it has less effect. Like, see 3 arrows here with the epi and only 1 arrow with norepi. So this is the norepi and epi, and other we talked about already. The advantages of vasopressin if this tachycardia, and advantage of dopamine that it can have no effect on the pulmonary vasculature. So like I said, this table, if you want to call it, this picture is really very important. So again, in summary, let me rub it off so that we can focus on. So in summary, the first point is that, like in this case, as you noticed, you can start the patient on, first of all, hypotension. The definitions are different, but if unit should have a policy or protocol, either they want to go with systolic blood pressure, diastolic, or MAP for every gestational age. So like in this case, the blood pressure, we all agree, was low. Nobody will say that, okay, we can observe, and especially no urine output for 12 hours. So this is not like a benign type of common physiological adaptation going on. Something has to be done here. So it's not bad to start with dopamine, like we see for the mild hypotension. But remember that dopamine is not good for pulmonary hypertension. And as in the second line say, that with PPHN, avoid dopamine and avoid high dose epinephrine. And problem with persistent hypotension is that we cannot use milrinone. Vasopressin has an advantage that it could be used with PPHN, but it causes it's the only problem is not good on the heart. If there is dysfunction, vasopressin is not good, like we talked about in the LEX 9. So this is the summary. So now let's see what happened. A little bit about the PPHN. So because this is, now we know either this is sepsis or PPHN, because it's not the classical PDA, which is left to right shunt. So treating the PDA at this point is not really warranted, because this is right to left shunt. So we have to work on PPHN. So PPHN could have two sides, one with the low preload and of course right to left shunt, either at most likely PDA level, and it could be at the PFO level. So on the left side, on the left side of the screen, which we showed down, the heart functions are normal. While on the left side, you see both same, low preload and right to left shunt, but now there is dysfunction. So you have to manage those differently. So in the first side, when the functions are normal, the systolic function and diastolic functions are normal, you can use, which we used here, you can use milrinone, you can use vasopressin. What happens if there is dysfunction? So vasopressin, of course, I will avoid because we talked about, but it can be used if needed. The milrinone could be used, but again, remember, like in this case, there was some hypotension, so just remember that. And the patient was already on dobutamine and inhaled nitric oxide. So now let's see what happens. So we discussed this part of the case. We discussed this table. So patient is here now, and as you see that, how the case was progressed from different pressures. So at this point, this was the saturation. So this was preductal. So this patient is definitely not improving on the PPHN side. So because there is need for vasopressor with this blood pressure, and after reviewing the table, as you see, norepinephrine probably is the better choice. So at this point, the epinephrine was DC'd and norepinephrine was started. And after 30 minutes, the blood pressure was noted to be up, the mean was up, and saturation improved. Again, this is preductal. So, at question at this point that treatment of PDA with right to left shunt, like should we have treated? The answer is, what do you guys think? The answer is no, because this PDA is not left to right. So what will you achieve by closing the PDA? Actually, when there is a strain on the heart, right side of the heart, is good to have a PDA because that can act as a pop-off valve for higher pressure. The second question is norepinephrine superior to epinephrine? Again, remember two things for PPHN and for tachycardia. If you have tachycardia on board and if you have PPHN, norepinephrine is better than epinephrine because it doesn't, it has minimal effect on the heart stroke volume, but it has almost no effect and it further decreases the PVR. So that's the advantage of norepinephrine. Okay, remember that. So the answer is, of course, for PDA is not advisable. Treat the primary cause, which is PPHN, and of course, norepinephrine would be better in PPHN. And some people use in sepsis preferably over epinephrine. But again, like I said, for sepsis is the unit choice. But if there is some pulmonary hypoperfusion, norepinephrine should be considered. So again, let's walk through the case. So this was the problem, persistent hypotension. Again, we talked about that what type of, once you are presented with, sort out, is it systolic, it is diastolic, what type of, in this case it was both. So again, this is the definition that systolic hypertension are usually due to the stroke volume problem, like in this case probably either it was PPHN or sepsis. We don't have any cardiogenic disease which suggests like dysfunction of the heart or any other structural problem suggesting that this. And what about diastolic? As we talk about, diastolic is decreased SVR and decreased preload. So possible could be bleeding, hypovolemia, or PDA. But this PDA has to be left to right shunt. Now, what about the other thing? So echo. So first, whenever you're dealing with hypertension, of course, start with thinking, is it physiological adaptation? Ask about the urine output. Look, monitor the baby, examine the baby, see the capillary fill, see the vital signs. Decide if it's systolic or diastolic because that will guide you which type of medication you're going to use. Then, of course, echo is very, very important because echo will tell you about, of course, in addition to PPHN and PDA, it can tell you about the functions of both the ventricle. If there is dysfunction, then as we know already that the drug choices are different. And again, going back to the same table, that how after having all the information, systolic, diastolic, and the pathophysiology is known, so now you can choose the right drug. And again, if look at the signs of perfusion, signs of sepsis, shock, because that can again add you to make a differential diagnosis before you can start the medication. So I hope you guys have learned something together today. Please do like and subscribe to our channel, and you guys have an additional comments or you want to discuss your experience with treating hypertension, please comment on that. You guys have a wonderful day. Bye.